So the reason we are here today is to thank you, our donors, and for Marty Deegan and Roxana Harper to share an important role that Baystate Health and Hospice plays in delivering care in our community. With families struggling to access care and even spend time with loved ones, our team has been more important than ever. Marty and Roxana will share stories and news with a vision for the future. They hope to devote a good portion of this call to providing you with helpful information and answering as many questions as possible. So for introductions, Marty Deegan is Executive Director and Chief Operating Officer of Baystate Home Health and Hospice. He has 24 years of finance and operations experience, 17 of these specific to healthcare and progressive leadership roles. Marty's a collaborative leader who has driven sustainable results in all the organizational roles he's filled. He's excited about the future for home health and community-based care and thrives on advocating for its value while empowering individuals who make it possible. Roxana Harper, Director of Clinical Operations for Baystate Home Health and Hospice. Roxana has worked for Baystate Home Health and Hospice for 28 years, dedicating her career to caring for patients at home and most recently at end of life. Her mission is to keep patients where they are most comfortable and support families and staff to make that possible. I am proud to turn the presentation over to Marty and Roxana.
Well, thank you, Scott, and good morning, everybody, and thanks so much for being with us this snowy winter Friday morning. I think I speak for everyone when I say it's been quite a year, and I think that's an understatement. But I like to say with every experience, good or bad, we like to reflect and learn as much as we can from that experience. And we certainly learned a great deal this past year in a lot of different regards. Before I get started, the one thing I always try to take an opportunity to do, speaking from my position, is really point out that although we're here at Baystate Home Health and Hospice, we're a small part of the financial picture at Baystate Health. We also are a very important part of that picture, and I like to remind folks that we have on an everyday basis over 1,000 patients in our care, or 1,000 patients on our census between all of our programs every single day, and we employ over 250 team members, from clinicians to administrative and support staff. So I always like to take the opportunity to remind folks of that we have a lot of responsibility for caring for patients and our employees, just like everybody else within the health system. So I'd like to speak a little bit about how the pandemic and COVID-19 has affected us here in home health and our patients. And I'll kind of go back to last March. It was just like everybody else, a very confusing time at the beginning, and information and different protocols seemed to be changing by the day and sometimes even by the hour. We were getting new information and having to disseminate that information to our staff to keep everybody, in the know and as best informed as we possibly could, because it was a very scary time. We were hit with something that nobody knew what to expect or how to deal with, and obviously that was the case in the hospital, and it was certainly the case in all healthcare settings, including ours. Ironically, before COVID-19 hit, we were actually preparing and pretty much expecting our DPH three-year survey any day. And so while we were waiting for that, while we were preparing for that, we had just finished reviewing and really beefing up all of our emergency protocols in our emergency preparedness plans, but had no idea that we would be putting them into action within a mere few weeks. And so we did just that. We were hot off the press. We took our all of those protocols and enacted them to the best that we could. And I can't say enough about this leadership team here and the management team. The one thing that I'm most proud of is that we worked side by side every single day. We were highly communicative, and we met on a daily basis and really were prepared to take this challenge on together. And I think that, again, speaks volumes to the folks I work with every single day, and I can't say enough about them. But the truth is, staff and patients, they were scared. They were scared. They didn't know what to expect. We were hearing things certainly, obviously within the system, but also the news media and the internet, and it led, it got people thinking in a lot of different directions, and that was a pretty big challenge for us to try to contain that and really educate folks based on the education and guidance we were receiving from Baystate Health. So we made it a point to be as highly communicative with our staff as possible. That was in the form of, we had daily huddles. We still have daily huddles. We did town halls. We did email blast communications, and we wanted to make sure that our staff had the most up-to-date and accurate information as possible to not only put their own fears at ease, but also so they could continue to deliver the patient care that we needed to. So with that said, we actually continued to deliver care in patient homes every single day, which, the hospital obviously had its challenges in caring for patients and trying to prevent the spread of this virus. But we also had to deal with that too in a different setting. We're going into patient homes where there were family members and other guests that might have been there that we actually had to screen before every single visit that we did. And to this day, we still have those screening protocols in place, and we talk about patients that are either COVID positive or that present, we call them PUI, patient under investigation, which means that they have the potential to be COVID or have been exposed to COVID. So we have to talk about those patients every single day and make sure that our staff are well prepared and protected to go into patients' home while doing that. So it's been a big challenge, and early on, it was certainly, as many of you might know, it's not so much the case anymore, but we had challenges with personal protective equipment in terms of masks and gowns and all of the hand sanitizers and all of the stuff that we needed to protect ourselves all of a sudden was in short supply. So we were faced with having to really triage patients even more. We resorted back to some remote visits and phone calls on visits that didn't need hands-on care, certainly with our psychosocial team in those types of visits. And I'm actually very thankful to my hoarding partner here, Roxana Harper, who actually was she must have been a Girl Scout because she actually was very, very well prepared and planned ahead. After we went through the first phase last spring, she really spent the summer stocking up. So we were very, very well prepared going into this latest phase since Christmas and over the recent months. So PPE supply hasn't been as much of an issue as it was early on, but nonetheless, we have to keep our eye on it day in and day out. We also had a lot of changes to just our regular protocols. Again, not only screening patients every single day, but it also, as with everybody else, changed all of our meeting protocols. Look what we're doing right now. We're remote, and that obviously changed a lot of our operations going remote and having more conference calls and things like that. We sent a lot of folks that usually worked in the office, and we hooked them up with remote work and the ability to work from home. So a lot of different changes that affected us, just like everybody else. And we had to learn how to adapt to that. And I think, again, I'm so proud of this team because we did a great job in doing that. I think one of the things we're most proud of, and Roxana will elaborate a little bit more on this in her presentation, but is something that we partnered with the hospital and hospitalists and the case management team at BMC and our community hospitals. We started this in December, and it's labeled the Early COVID Discharge Program, and really we really demonstrated our value in really creating capacity for folks that were ready to go home, maybe not in traditional sense where they might have spent another couple of days in the hospital, but as you know, the hospital needed to make sure they had room for new COVID patients coming in. So we enacted this Early COVID Discharge Program where we took over 100 admissions that we normally wouldn't have taken, got them hooked up with remote monitoring in terms of telehealth and their vital signs, and monitored those folks every single day while they were on that. And like I said, we've taken over 100 patients earlier than we normally would if at all, for that matter. And it's been a very successful program. Only a handful of them, small percentage of them, ended up having to go back to the hospital. So we're pretty proud about that. Again, I'll let Roxana kind of elaborate a little bit more on the details along that. But my favorite, we're going to give you a couple different patient stories throughout our presentation, but I wanted to speak to one of my favorites that we experienced I think it was late last summer. We actually had a hospice patient that was in the hospital as part of our general inpatient program. And as you know, there's quite a few restrictions on visitation, and a lot of family members couldn't be with their loved ones as they were experienced their journey of end of life. And this one patient, her daughter spoke with our chief medical officer, Dr. Jowdy, and was very distraught about the fact that she couldn't be with her mom as she was passing. And so we obviously needed to, be there for her and support her in that anguish. But one of the things that she mentioned to Dr. Jowdy is how much her mom loved Neil Diamond and Neil Diamond music. So knowing that, and we wanted to do everything possible, we actually, it was a Sunday, I remember, and Roxana here and Dr. Jowdy and I, along with the hospice nurse, I downloaded Pandora. We actually got a spare smartphone, iPhone, and I met Dr. Jowdy outside the hospital. He brought the iPhone in, and we hooked her up to the Neil Diamond channel, and she was able to listen to Neil Diamond music as she was in her hospital bed, and again, going through her journey of her end-of-life journey. So we're pretty proud of that. Her daughter was very, very appreciative and thankful of that, and we're just glad we were able to comfort that patient when she needed it. So again, that's one of my favorite stories, and Roxana will certainly share a couple more with you. And I'm going to turn it over to Roxana now, and she can talk a little bit more about our programs and the things that we've been doing.
Well, good morning, everyone. As in my bio, I've been at Baystate Home Health for 28 years, and I am extremely passionate about home care. So I have to keep myself on track, otherwise I could be here all day talking to all of you. So I'll talk about all of our programs over here. So we have traditional home health. Those are patients that come from the hospital, a skilled nursing facility, rehab, or right from their physician office that have, an illness, a surgery, and need some part-time intermittent care in their home to return to their independent state. So these people come on to service, we treat them, and then they actually are discharged back to their home, back to their community. So that's home care. As Marty was talking to, during COVID, we did develop the early COVID discharge program for these home care patients. So they actually came from the hospital, and we took them home, and we had our telehealth equipment installed same day that the patient went home. We have a nurse who is actually in the office, and she would monitor these patients 3 times a day, their vital signs, so their oxygen level, how are they oxygenating at home. Most of these people did go home on oxygen, so they were still pretty sick and needed close monitoring at home. So 3 times a day she would do that. Once a day she would actually do a video chat with them. So our equipment has a tablet, and she sits in front of a camera as you or I are right now, and she would actually video chat with them. So she would see, how they're feeling, if they're short of breath, how their color was. And if they really weren't doing well, she was able to contact the doctor and get any orders changed right away so that these people didn't have to go back to the emergency room or back to the hospital. And we've actually had really good success with that program. And we still have over 30 patients on there, and we're getting at least 2 to 3 patients every single day. So that was an exciting thing that we were able to do for home care. We also have a new program that we started to develop last year. It hasn't gotten the traction that we had hoped, obviously because of COVID, but we're still working that, and that is our community palliative care program. This is different than traditional home care because this is not a covered service under traditional insurance. So we have a nurse practitioner who is able to go out to these patients on a consultative basis. She actually works closely with the primary physician to work on advanced care planning for these patients. One thing COVID has taught us is end of life could be at any moment, and a lot of people really don't know what they want their end of life to look at, or they do know, but they haven't communicated that and haven't written that down. So if you're sitting at home and you don't have an advanced care plan or a health care proxy in place, you could potentially go to the hospital, have CPR, be put on a machine when really, in fact, you did not want that. So COVID has taught us that it's very important very early on in your life, even myself or even my children, that we're able to have that conversation with our loved ones, with our physicians, and have those documents in place so our end-of-life journey is really what we choose it to be. So this program is important because we're able to go to patients' homes and work on that with them, have the document signed, and we work with the primary physician so that everybody is on the same page. That's kind of an important thing that we see moving forward as we move to more community-based health. This is important for us, and we're excited to move forward. Also, we have a pediatric palliative program that is a state-funded program. These are kids that are under the age of 18 with life-limiting diseases. So they can have cancer, they can have neurologic diseases, some developmental disabilities, and they're at home, and we have staff, we have nurses, we have social workers, we have child life specialists. Music therapy is very, very exciting, and we're able to go into their homes and we're able to take care of them and support them as they journey through potentially their end of life as well. And what we see is as these children do end up at end of life, we're able to transition them from the palliative program onto our hospice program, so they're able to then spend their entire lives comfortably at home, being taken care of by family members, in their bed, in their home where they're most comfortable, and then they end up passing as well. So as we transition from home care potentially to community palliative care to pediatric palliative care, then we end up with our hospice program. This is something that actually I have just gotten into as a director. I was traditional home care before, and truly I was afraid of hospice and I was afraid of the death and dying. But once I actually got into the program and learned what the nurses and all of those staff members do every day, I have become extremely passionate about that, just as the other programs. So when someone is at their end of life, most likely they're not going to want to spend it in a hospital bed or a nursing home bed. They're going to want to spend it in their own home, surrounded by their own things and their families. So what hospice does is we're able to provide care and support so that these families are able to care for these patients in their home. We have nurses, we have social workers, chaplains, home health aides. We've actually started a music therapy program as well, because as Marty alluded to, with Neil Diamond, music actually has a way of comforting and supporting these patients at end of life. So, our music therapist sings with these patients. They play music. They listen to songs together. They talk about what these songs meant to them. So this is an exciting thing that we have started as well for our hospice program. And we also, after the patient does pass away, we do provide bereavement programs for the families that they've left behind, which allows them to bereave and grieve appropriately, and have that support at home, which is extremely important as well. So that in a nutshell are the 4 programs that we have here at Baystate Home Health and Hospice. We also have the telehealth, which we did allude to. That is, we have found, obviously through COVID, we're not able to be in the homes with a lot of these patients, so video capability has really taken off in this time. So we're really looking to build our telehealth program. As we've tested with the early COVID discharge patients, we're looking for cardiac patients, people who have COPD. You hear those ads on TV, or CHF, congestive heart failure. We may be able to take these programs and bring it to these patients with these disease processes, keep them home, and keep them doing their own self-care while someone is video chatting with them, and able to keep them home and out of the hospital. So that's a very big initiative for us. And currently, telehealth is not something that's reimbursed under insurance. So we're giving this as an additional service to patients that really need it, and we're seeing a lot of good things come from that. With hospice, we also have our veterans program. which is, I think, extremely important in the community. We have veteran-to-veteran support that I think really makes a difference for veterans who are continuing to suffer through PTSD. We're able to hook them up with another veteran who maybe, you know, was going through the same thing, was in the same war with them, you know, and they're able to just support each other, which is big. We do a pinning program, a certificate program, where we actually give a pin and a certificate for the branch of service that these veterans are in. And the patients and the families are extremely, extremely happy when we're able to do this for them. They also do a Veterans Cafe, and our staff also do community events to support veterans in the community. One thing that I'm actually quite excited about is a program that we're also going to develop for hospice, and this is called a Journey Volunteer. So currently we have volunteers who, not right now because of COVID, but they're able to go into the home and sit with the patient, you know, who is on our hospice program. They can read to them, color with them, paint fingernails, you know, just support and be there. But with COVID, we weren't able to do a lot of that. So once we started thinking of some new ideas and trying to be innovative with video, we came up with a Journey Volunteer, which is a program that is really just getting off the ground. So the idea of a Journey Volunteer is we have volunteers all over the country, hopefully going to be all over the world, that we can hook up with one of our patients, either a pediatric patient or, you know, an elderly person in their home, with an iPad. And they're able to take these patients on a virtual tour of anywhere they want to go. So, you know, everybody has a bucket list, you know, of something that they want to do, but these people aren't able to do that. So we find a virtual volunteer who maybe lives in Hawaii and can take a veteran to Pearl Harbor, or, you know, maybe somebody has a family member or a grave somewhere across the country. They're not able to get there to visit that grave site. We can take a Journey Volunteer. They can go to the grave site. They can put flowers. They can play music at that grave site. Or a child who is not able to go to Disney World. So this Journey Volunteer could potentially take them there, take them on a ride. You know, it's kind of an exciting way to be able to take someone on a trip. You know, and it's not just watching a video. So, you know, you can watch a video of anything, but that's not personal. So the Journey Volunteer is able to take someone on a personal journey wherever they want to go. So I'm really excited about where that can go. And these ideas, you know, and a lot of this innovation came from COVID. You know, we may think, obviously, COVID has been a horrible, horrible thing that's happened, but it's also brought people a little bit closer together, and it's brought, you know, innovation and a lot of things that may have taken a long time. We really had to push it quickly because of COVID, and that's maybe a little positive piece that came out of it. So I will close. I've given you quite a lot of information, but I do want to just tell you a couple of stories as well. And then they really are both hospice, because those are really meaningful things that happen. So we had a patient who lived in a home with his wife, and they were hoarders, and the home was really not a safe place to be able to take care of this patient, but he really wanted to be at home with his wife for his end of life. So our social workers and our nurses supported the wife and supported him, and, you know, let them know we really just needed one room cleaned out where we could get his equipment, his hospital bed, his things that he needed to make him safe at home. The wife wasn't sure she was going to be able to do it, and she really was pushing for a nursing home for him, but he really didn't want to go. So with continued support and little bits day by day, we were able to clean out a bedroom and get a hospital bed in there, get all his equipment in there. The wife was able to get notebooks, and she was able to write everything down so she didn't forget anything. They didn't lose their identity. They didn't lose their self. They didn't lose, you know, what they had lived in the house, but we were able to get one room where he could safely be and, you know, pass at end of life in his home comfortably, when his wife at first said, you know what, there's no way I'm going to be able to do this. But with the help of hospice, they were able to do that. So that you know, is pretty meaningful. And then the second story actually happened when I had pretty much just taken over hospice, and we got a call from Boston Children's Hospital about a 1-week-old baby that lived in the Springfield area, and the mother had delivered at Baystate, and the baby was born with a brain tumor, and she was not expected to live. So they wanted to send the baby home to pass. Our hospice team honestly was in a panic because who is equipped to take care of a 1-week-old baby during end of life? So we worked with our pediatric palliative specialists, and they were able to work together to get this baby home, get her comfortable, get the family around them, and she passed within 10 days of coming home. So this just shows really what we do. I get emotional because it's a big deal, but we thank you very much for your support of Baystate Home Health and Hospice.
Thanks, Roxana. So as you can see, we're very passionate about what we do, and we definitely feel we play a significant and a critical role here within the Baystate health system in the continuum of care, in terms of providing access to patients' access to care, I should say, certainly avoiding rehospitalizations, advanced care planning, and just really caring for patients in their home where they are most comfortable and where they want to be. So the other thing I just wanted to point out touch a little bit more on our vision and where we think we're going here. And it's really, we will certainly maintain our traditional lines of business in terms of the post-acute discharges and getting folks independent and healthy again in their homes. Again, trying to prevent them from going back to the hospital. Certainly on everything Roxana talked about in terms of hospice and palliative care. But we also want to enter the community wellness arena, if you will, in that space. And really, the way we say it, our traditional business has always been in post-acute care. We want to get into pre-acute care, if you will, and really be a strong and valued partner with primary care, in primary care physicians and the clinics and everyone else along the continuum to kind of serve both of those spaces well. So although there's so many benefits to the work that we're doing, and as Roxana alluded to, we're finding so many innovative ways to do it and new ideas to meet the demands of our patients in the community, in both, again, the pre-acute and the post-acute space. Traditional reimbursement and other challenges really make it difficult at times. There's challenges in terms of staffing, the market, and there's a lot of, as you can imagine, a lot of different challenges within healthcare. And the good work that we're doing, as I alluded to when I first started the conversation, we have over 1,000 patients in our care every single day. But the reimbursement, if you looked at the revenue side of it and the financial side of it, it doesn't necessarily reflect that. And that's the thing that we're really trying to do too, is really educate not only our partners in care, our referral sources, and all the other stakeholders within Baystate Health and in our community, but also our patients in the community at large, and just letting them know why we're here, what we're here to do, and how we can be of value, to their lives and to the community overall. So again, I just wanted to thank everybody for tuning in to us this morning. Again, we couldn't do a lot of this without your generosity and the things that you've brought to us, and we couldn't be more thankful for your support and listening to us today. So thank you. I'll turn it back over to Scott, and we're certainly here to field any questions you might have.
Thank you, Marty and Roxana. And Roxana, this is an emotional topic. I cannot tell you how proud I am and humbled to work next to you both. And this, I as a care provider for my parents, I've gone through this 2 times, and you brought back some really really good memories. Just on a personal note, my dad was an artist, and I had redone a house next to me. And when he came back for hospice, we decorated the whole house with all his artwork. First time I ever saw the house. But I was kind of laughing too. I never heard more Ray Charles in 48 hours in my entire life. So it wasn't Neil Diamond, it was Ray Charles by his choice. So my kids and my wife and I pretty much have every Ray Charles song memorized. And I completely forgot that the program because we live outside of the area, they came in and pinned my dad as a veteran too. And what was really nice is my son, who was leaving for active duty the next week, actually did the pinning. So there's a lot of emotions that happened, but it was a very positive experience for our family. For all of our attendees, you're more than welcome to submit questions. We have a lot that were submitted ahead of time. And forgive me, both Marty and Roxana, if they're repeats. Some of them might be repeated. but these are really good ones, I believe. For either of you, these questions are open. Can anyone call up and ask for a home health visit, or is there a process?
For home health referrals, we do need a physician order. So what we ask is if anybody out there, has a loved one that they think may need home care, or they have any questions. If they have questions, they can certainly call, call here at our main number, 794-6411. And we can help answer any questions, but then they would need to speak to their primary physician, and they could make a referral for us.
And just to add to that, so home health and hospice are highly regulated as all settings in healthcare. And I think that's a good point. We're a Medicare certified agency, so we have to follow the protocols that are prescribed by Medicare and insurance carriers. And that's kind of a contrast to a lot of folks hear about other private duty home care agencies, or the homemakers and companions and those types of things. Those are more not regulated, if you will. I'm sure they still have protocols, but you can call those directly and order a nurse or order a homemaker. We're a little bit different in that, like Roxana said, it needs to come directly from a physician's order.
Thank you. Question just submitted. How far does home health and hospice stretch east, west, north, south?
Take that.
You want to take?
Yep, I can take that one. So we actually cover quite a big area in the Pioneer Valley. We have 3 different branches in home health. We have our central branch, which primarily covers the Springfield area and the immediate communities around Springfield. But we also have an east and west branch. The east branch is kind of a combination of the old Mary Lane VNA and the Wing VNA, and it kind of covers the Ware and Palmer area and some of those surrounding towns. And then the west, our west branch was the former Noble VNA, and that covers primarily the Westville area, Agawam, and some of the communities around there. So we do cover quite a bit. The one area that we're not as present in is kind of the northern Franklin County area up by Greenfield and areas around there.
Thank you. And you alluded to insurance. One of the questions came in, does the insurance cover all expenses?
Yes, for home care, they do cover, and for hospice, most of the things are covered. Some outlier things, specific wheelchairs, some, I'm trying to think like incontinence supplies and things like that, they may not cover. But through some of our funds, we're able to give some of that as well.
So, and I'll add to that as well. So primarily, in hospice, we're about 90% coverage with Medicare, and in home health, about 50%. Those two payers in particular don't necessarily pay for the service that we provide. They pay on a case rate. So hospice pays a set amount per day. So whatever care we have to give, we live within that payment per day. On the home care side, it's a lot more convoluted and complicated, but based on the diagnosis and the initial assessment and the care plan, we basically get a case rate, just like in the hospital, it gets a DRG. And so we get one payment, and we have to deliver the care within the confines of that payment. So most of our care is coverage. There's some kind of coverage, but although it's up to us to kind of manage within that. And sometimes when you're trying to give the patient a little bit more, it does stretch we can just stretch the dollar a little bit more, if you will. We also do, we're a mission-based organization, so we typically don't turn anybody away as much as we can avoid it. So we do depend on some indigent funds sometimes when patient has no coverage. So we would do something like that, but those instances are relatively few and far between.
Thank you. Another question just submitted. How much does it cost for a veteran to access the Veterans Program? That sounds wonderful.
Yeah, if someone is on our hospice care, there is no cost to join the Veterans Program. If someone is out there who is currently a veteran that wants to be part of our Veteran Volunteer Program, they can call the 794-6411 number. They can ask for Sherry Langevin, who is the manager of that program, and we could get someone set up for that.
And on top of the actual the patient, patient veterans and those types of things, we're also doing things in the community as well. We have a vet-to-vet cafe, I think. Again, this was pre-COVID, so we're hoping to come back to this soon. We did something, we actually put on a program that's called Honor Flight, which is a very, very powerful story about this program that actually brings World War II and now Korean vets to Washington, D.C. to be honored. And it's a very, very powerful and very special program. So we try to do some more community things like that as well, even if they're not patients, but it's really, we do, like Roxana said before, we do a lot of pinnings and things like that for our patients that are veterans. So again, no cost to becoming part of that.
Thank you. And I know you both talked a little bit about palliative care. How would you basically describe the difference between hospice and palliative care, and how do you transition people to hospice care?
Yep. So if a patient is still getting some treatment, so palliative chemotherapy, palliative radiation, they actually don't qualify for hospice care. So that's where our community palliative care comes in. They do a lot of, symptom management and support of patients to get them ready for hospice, so that, once they decide they, can't tolerate the chemotherapy, or they really just don't want that and they want a little bit of, of a quality of life, that's where we take and we transition them directly from the palliative program to our hospice program. It's just honestly a referral that comes over from peer to peer. Dr. Jowdy, our medical director, reviews the chart to make sure that, the patient has a diagnosis and, certifies that they are at end of life. We can't have a patient on hospice, for 2 or 3 years. We want them on for more than just 1 day, so they're able to get the benefit of hospice and that support, especially for the family. But that is a very seamless and easy transition from one program to the other.
Thank you. And Roxana, I believe you talked about this, but I can't stress the importance. Question, are there any advanced planning steps people should take to protect themselves and their families before the need for home health and hospice? I know you talked about it, but it's probably worth saying again.
Yep. So again, that is the goal of our community palliative care program. But anybody now, even if you're not part of that program, there is a healthcare proxy form, which you appoint somebody in your family. It could be a close friend to make decisions for you if you're unable, and you have verbalized to them what your wishes are. And then in Massachusetts, there's a MOLST form. It's Massachusetts Order for Life-Sustaining Treatment. That's a form that your primary physician actually signs with you, and it says you want to be a DNR, do not resuscitate. So you actually keep that in your home. So if something happens, you call 911, and you're in a situation where you may need to have CPR, the compressions to the chest, or to be artificially breathed for. You actually have that form, and it says, I do not want CPR, I do not want this. And so when the EMTs come to your home, they actually will see this, and they won't start that care, and they will allow you to just pass it home and be comfortable. They'll call a doctor in the ER, so that you're able to comfortably pass at home. So really, COVID has taught us that you really need to be talking about this. Again, end of life can be any minute for all of us. And so we really do need to have these documents so that everybody knows what your specific wishes are, and you're the one who drives your care at end of life.
Thank you. Some questions are coming in quickly, so these are great. Next question I have right here: who is the supervising department? Nurses, the emergency room?
For which program? So when someone is on home health, our nurses are case managers, and they provide care with collaboration from the physician. So it can be a primary care physician, it can be a surgeon, it can be a neurologist, it can be an infectious disease doctor. We collaborate with whoever is taking care of that patient and ordering our services.
And the care is, as Roxana alluded to, the care is managed by a case manager who has a caseload anywhere from 25 to 30 patients that they're responsible for coordinating the care for that. And those case managers are overseen by another clinical manager that kind of oversees the whole team within that region.
Thank you. Next question just came in. How do you educate doctors and patients so more patients may receive palliative care?
I'll take this one.
Okay.
We have an ace in the hole, and his name is Dr. John Jowdy. So we have an on-staff chief medical officer that we hired about 2 years ago, and on top of many other things that he is doing, a primary responsibility of him is to really speak physician to physician and advocate for the work we're doing, and really kind of educate his colleagues and counterparts in other settings. On top of that, we do things like this. We constantly have, again, a lot of this is pre-COVID, but we've had seminars and in-service sessions over at the hospital with hospitalists and in primary care and those types of things. So we do our best to try to get the word out, face to face.
Thank you. This one came in before one of our attendees. I know you are constantly, I have many friends who were unable to be with loved ones when they fell ill or passed away during the pandemic. How did your team help a loved one stay connected to patients when they could not visit in person?
Absolutely, that was a big one for us, and that's where our telehealth or our video capability. So it was cell phones, it was iPads. It was connecting through that either, with video chats and the different platforms that are out there to be able to do video to video. That was the biggest thing, and that's why we really want to keep that virtual piece going, where we're able to connect family members across the country, connect volunteers when we're not able to get in the home, because, saying goodbye to someone isn't ideal to do it video, but it's honestly better than not being able to say goodbye at all.
And then just to add to that real quick, and this kind of ties back to the earlier question about reimbursement and for services, telehealth and the technology part of all of this is one area that is not reimbursed. CMS has not yet. There's been a lot of talk of it, and I think on the physician side and in some of those settings, they can certainly be reimbursed for telephonic visits and things like that. Right now, that's not the case in home health. So again, as innovative and beneficial as it is to our families and patients, it's not something that has been reimbursable thus far. Again, I think that may change. I think the pandemic has taught some folks the benefits of it, but right now that's something we do struggle with from a cost perspective.
Thank you. I have a suspicion you might have a similar answer to this question. You both have long careers in healthcare. What have been the biggest changes that you've seen in healthcare and home health over these years?
That is COVID and not being able to make visits, being dressed in full PPE from a gown to a mask to goggles to gloves. That really has been the biggest change. Patients being afraid to let people in their home, honestly, is another big thing. So that is the biggest change. And really, maybe it's insurance companies and physicians and everybody just learning different ways to adapt and to do things that were so easy to do before.
And so I would definitely echo that. And technology. Again, I think it's not to say that it was just found during COVID, but I think it definitely took on. It became front and center when it was needed. The other thing I would just add, and this is primarily speaking as from home health and community-based care, is there's always been, we know, we work it every day, but we've known for a long time the benefits that home health and hospice and community care can bring to the communities and to patient lives. And I think we're starting to see other people catch on to that. And I don't mean to be disrespectful to anybody, but it just wasn't always front and center. And I think the more that, we show our value, and our value proposition is apparent to folks, they know that we can do this, and that it's really where patients want to be. It's the most affordable setting to treat patients. And I think that's come a long way in the past couple of years, and certainly this past year.
Thank you. We have time for a couple more questions. Very exciting about the Journey volunteer. That was really, really interesting. So one of the questions we had submitted ahead of time, that there's so many dedicated and wonderful hospice volunteers over the years. Do you see opportunities for people to begin volunteering again?
Yes. So again, COVID is unfortunately still still here, so we're not able to go into the homes, to do those types of hands-on, but we're really trying to do more of the virtual, so we're doing virtual volunteer programs. We are still recruiting for volunteers. Sherry Langevin, who does our veterans program, is the one who's in charge of that and is actively recruiting. And, as we do that, we really want to get this Journey volunteer program moving because, we don't know how long COVID is going to be here, and how long we have to, still separate. So we want to be able to use technology and get these volunteers because patients really, really enjoy that and families enjoy that as well.
Thank you. Somebody submitted a question. What kind of grief counseling and support do you provide for families or loved ones?
Yep. So we do have social workers and chaplains who are able to provide bereavement support, in the home immediately after death in the home. And then we do have a bereavement program where they follow the bereaved family members for a year. So they do get mailings, they do get calls, and they can call in and talk to a chaplain or a social worker at any time during that year if they're having, any feelings that they need to discuss with someone.
The other thing that we're quite proud of too in our hospice program is, pre-COVID, we had twice a year we had a memorial service at a local church that honored for those families that wanted to participate, that honored their loved one that had passed. This past year, obviously, we were unable to do that, but I think we just were scheduled to have a virtual memorial service, of course. But it's really special. It's kind of, again, it's a year later, and it just recognizes and honors those patients that have passed on our service.
Thank you. We just had a question submitted. I think the person's probably in the Franklin County area. Do you see the services expanding into Franklin County in the future?
I'll take that. Yeah. So we used to have a presence there years and years ago before I was here anyways. I think Roxana was out in the eastern region at that point in time. And it kind of, it didn't take off or whatever. I'm not sure exactly what why it didn't take, but definitely is something that we want to do. But as I accepted this role in charge of the agency, I wanted to make sure that we our own backyard, and before we expanded, that we were solid in delivering safe and quality care to the patients in our immediate catchment area. So the quick answer is yes, absolutely. We are looking to expand, and we want to come north, and we want to partner with Franklin Medical Center. But I want to make sure that we do it responsibly, and we don't just just throw a want to do it well. So it takes some planning and it takes some resources. So that's definitely the plan. I can't give you a timeline for that, but hopefully, it'll be sooner rather than later.
Well, thank you. And I'll wrap it up with this question. We have many donors on the call, so we want to obviously thank them for all they've done. And many people support Baystate Home Health and Hospice, and have included the organization in their estate plans. Can you share anything about the impact of the gifts that you receive?
I'll start there if you want. Absolutely, it's been so valuable to help in areas such as complementary therapy, such as music therapy, massage therapy, and different things like that. Supporting some of the technology needs that we need, again, telehealth. Some of these things that we don't necessarily get reimbursed for, or even when when someone does come to us with no coverage, no insurance coverage, and we're able to help them out. We've actually funded some funerals. I believe we had to, we kind of partnered with the funeral home, and we're able to bury patients that didn't have anybody else to help them with that. So things like that, when when the need is there, and we can't say no. These funds have been so valuable. I can think of another opportunity a couple summers ago, on a pediatric palliative family had no air conditioning, and it was in the 90s for a week, and so we went out and bought an air conditioner, and we were able to access certain philanthropic funds for things like that to help with palliative patients and their families. So it's been just invaluable to us because we wouldn't be able to do it without it. I don't know if you had anything to add to that.
Well, that, and also, funds we use them for fun things, as well, that we're not able to do, especially for our pediatric palliative program as well. We were not able to do a picnic for them. So we did a drive-through here at our office, where we masked and we socially distanced, and we were able to have, bubbles and water fountains and things that they drove through. We did, for Halloween, we had a drive-through trick-or-treat. So, our staff were dressed up and we decorated our cars, and we had, these kids come through with their families in the car, and we did a trick-or-treat with them. So really, it's trying to do anything we can to make people's lives just a little bit brighter.
And just one final comment on that as well. We've also used funding quite effectively. We've recently really reinvigorated our training, our education in quality teams. We've actually used some funding to build a sim lab here in our office. Again, COVID kind of prevented a lot of folks from coming in to do it, but we were able to buy training equipment and training materials and things like that with some of this funding, which is obviously very, very valuable to making sure that we have highly skilled staff and they stay up on their competencies and things like that. So some of the funding went to training and education programs as well. And again, we're very thankful for that.
Thank you. I have one last question, and I tell you, it was great to get these questions because people really have a lot of thoughts here. And this is a kind of a big one. It's one of our listeners. What is happening with the opioid crisis? So I guess maybe you've said it many times. Maybe you wrap it up on how you've learned and how this crisis, the opioid crisis has affected your area.
Yes, so, a lot of our patients that we get out of the hospital are patients who do have issues with opioids, and, they have heart issues or other issues that have happened due to their consistent opioid use. So we take care of them to the best of our abilities at home. We provide support with them, and then, a lot of fear is with our hospice patients and using opioids. So we do a lot of education with them as well. We use alternative treatments if we can, and then just do a lot of education that if prescribed correctly, they are, really good for pain control. And, there's a stigma around it as well, but if used correctly, it does provide the pain and support. So that does help our hospice patients. So, we do see a lot more of it in the community, absolutely. But we really try to support these patients and, get them into treatment programs or whatever they need in order to, lead better lives.
I was just going to say that too. Our psychosocial team, we have a great team of social workers that actually can have a lot of contacts and a lot of resources at their disposal. So we do very, very well with connecting patients to these resources, whether it be some kind of addiction or another need. So again, we play a part of that in the community, and that's kind of goes back to what I was saying a little bit before too, being in the post-acute arena certainly, but we want to be that agency that's also in the pre-acute, in the community-based, providing community-based care, healthcare, and services, quite honestly, right down to nutrition and counseling and those types of things. So we have a lot of aspirations and a lot of things that I think we can do to really have a positive impact on our community.
Well, thank you both. I'm going to wrap it up right here. I want to thank, on behalf of Baystate Health Foundation, everybody who joined us today on this call, and for your participation, your questions, and for your generous commitment of all your support and your gifts to Baystate Home Health and Hospice and to Baystate Health. Just please know gifts of all sizes really make a meaningful impact. A very huge thank you to both Marty and Roxana. As I mentioned, I'm so proud to work with both of you, and thank you for sharing, a really meaningful work that you do. And I also want to recognize the people that really put this together from our team: Kylie Johnson, Kate Roberts, Kathy Bronner, and Andrew Pond. Thank you for putting it all together. So on this, on our Friday, I wish everybody a gentle snowstorm. I think the snow is stopping. An enjoyable weekend. Let's all hope for some warm weather coming our way. And again, thank you for joining us. And Marty and Roxana, thank you for your time. Have a great day.
Thank you. Have a great weekend.
Have a good one.
Bye.